Thank you so much for being here, Dr. Orbuch. I wanted you to take the time to introduce yourself, let people know exactly what you do and how you got here.
Sure. Thank you so much for having me to do this event. My name is Dr. Laurence Orbuch. I'm in practice here in Los Angeles. I've been in Los Angeles for 10 years. I previously was in New York City. I've been in practice for, this is my, I can't believe I'm saying this, my 27th year in practice. I'm an OBGYN, specializes in minimally invasive surgery and robotic surgery. Primarily, and my practice is focused on treatment of endometriosis, and that's my area of interest and expertise. And basically, my motivation for going this route is because I saw such a need for care for women with endometriosis, and very few practitioners available who were knowledgeable in treating it, and skilled surgeons. I think even today, there's probably less than 100 really experienced, skilled endometriosis excision surgeons in the country. And that brings up an important point, which is how you do the surgery. And then I'll work backwards and explain what endometriosis is in more detail to clear the air and dispel a lot of misconceptions and falsehoods that are out there when you randomly Google to get the information. I'll start off giving a little brief explanation of it, and then I'll talk about the surgery. So the endometrium is the lining in the uterus, and that's what you shed every month when you have your period. Endometriosis is a condition where you find cells that resemble that lining, but they're outside of the uterus. Now, make note of the fact that I said resemble. They're not coming from the inside of the uterus. There was a theory that was postulated over a century ago by a general surgeon named Dr. Sampson, who coined Sampson's theory, which was, and to no fault of his, given that he was practicing back in the early 20th century, and he found these lesions that he looked under a microscope to analyze them, and they looked like the endometrium. So he assumed that they were coming from retrograde flow of menstrual material during someone's cycle. Instead of it coming out vaginally, it was getting shot out of the fallopian tubes into the abdomen. So that was his theory, and that was the running theory for many decades. And I'm sad to say there's still some OBGYNs that tell patients that's how it gets there. But fast forward to more modern times, with better analytic technologies available, we've discovered that these cells are similar to the endometrium, but they're not identical. So what's extrapolated from that is that they're coming from the same progenitor cells, but they are not coming from the same source, which then led more correct pathophysiology origin of the disease, which is metaplasia, meaning when you develop as an embryo in your mother's womb, there are 3 different cell lines that differentiate into all the different body parts and organs and everything. One of those cell lines, the mesoderm, for some reason, there's some genetic miscoding or aberration that during cellular migration, when these cells migrate to different parts of you and then differentiate into different structures, for some reason, some of these cells get dropped off in places that they shouldn't be. And then something either in utero during fetal development or after birth, at some point, they get triggered to differentiate and they become these endometrial cells. And that's why, if you also look in the literature, there are case reports of endometriosis being found in every organ and every body cavity or surface in the human body. Example, I've had patients with pulmonary endometriosis, or in their lungs, or on the diaphragm, nasopharyngeal endometriosis. I had patients who get these massive nosebleeds during their period. And sure enough, when you investigate, you send them to an ENT, an ear, nose, and throat doctor, and they scope down their nose and they look and they find these big, beefy, red, purple, black lesions in their nasopharynx, and they biopsy it. It's endometriosis. It's been found in the thyroid, brain, you name it, it's been found. More commonly, it's found in the abdomen and pelvis, either on the urogenital tract, meaning uterus, tubes, ovaries, ureters, which are the tubes that go from the kidneys to your bladder, on the bowel, rectum, small intestine, appendix, the lining inside the abdominal cavity, and also it could be on the liver, on the diaphragm, the gallbladder, anything that's in the abdominal cavity, because it's one space, the abdomen and pelvis. So those are the more common areas. So next question is, how do you treat it? So unfortunately, the majority of physicians will treat it using a modality called ablation, either lasering it or burning it with electrocautery. And the recurrence rate is, on the conservative side, is 35%, but it's probably on the more liberal side, when you look at the literature, it's probably 50+%, which means that probably half or more patients who have ablation will end up needing surgery again. So you ask why? Because if you're burning something, it's a 2-dimensional treatment, because you're treating the surface. The Endometriosis is something that is progressive. And each month when you cycle, the same bleeding and release of all these inflammatory mediators and things that happens in your endometrial lining that you shed happens in these implants, but it has nowhere to go. So there's no outflow for it. Like when you have your period, you wear a tampon, use a pad, and everything comes out. When it's confined on or in another structure, it just keeps adding more volume to the lesion. So when you do ablation, if it's 2 or 3 millimeters on the surface and I'm just burning the top of the surface of it, it's referred to as the tip of the iceberg effect. I don't know what's underneath it. It could be conical in shape. It's like you're treating the tip, the peak up here. It could be 8 millimeters at its base and 10 millimeters deep. So what happens when you burn it? You're just basically burning the surface and creating scar tissue on the surface that's basically encasing the disease that's underneath it. And frequently people either don't feel better, they feel minimal relief because you partially treated it, and then they rebound to where they were to begin with. The proper way to treat it is with excision. So you're actually excising or dissecting and removing the disease. So when you do that, you can see the full extent of the lesion. You can see where the endometriosis lesion ends and where the normal tissue is beneath it, so that it's clean and free of disease when you're done. And also, if things are adherent to each other, if they have what's called adhesions because of the inflammation, it can cause structures to stick to each other that ought not to be stuck to each other. So you can dissect that free and recreate the normal anatomical landscape in the abdomen and pelvis, which is critical as well. The other thing that's a misconception is when people talk about recurrence. Recurrence with excision doesn't mean it's going to come back where it was removed, because once it's removed, it's not coming back there if you've got the whole lesion out. Recurrence means that the same pathophysiology that led to these lesions popping up where you found them, theoretically, could result in new ones sprouting in other places. That being said, generally, and again, you can never say never and never say always, but generally, once you're an adult, usually whatever sprouted is what was meant to be. So the recurrence rate, when you look at the recurrence rate between excision and ablation, it's dramatic. There's a dramatic difference because with excision, it's under 10%. Most papers and studies that you look at, the numbers range between 3 to 9 point something percent, whereas with ablation, like I said before, it's between 35 and 50% roughly. So that's a massive difference. The next question is, why doesn't everyone do excision? And the answer to that is it requires skill and experience. When you're doing excision, you are excising disease. So you need to know where you're at. You need to know the anatomy adjacent and beneath and all around what you're working on. And that takes training and skill and experience. It also takes time. And logically, if you think about it, if I just go in and look and I see, oh, there's a spot here, a spot there, I just go, bzz, 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 I'm done in 15 minutes. If I see the same findings, but I need to excise all of the disease, that could take a few hours. In extreme cases, with a real deep infiltrating disease, which we call stage 4 endometriosis, it could take many hours. And if there are deep infiltrating lesions, for example, into organs like your rectum or other parts of the colon or small intestine or the bladder or the sidewall of the pelvis over the ureters, you need to do major surgery to excise the disease and possibly also resect part of major structures or organs to do that, like bowel resections or resecting part of the bladder, for example. So that's why it's more involved surgery, but it's the right surgery to do. In theory, if you have really superficial lesions, the argument for the other side is, oh, why would you subject someone to more significant surgery or more invasive procedure if you can do just an ablation of these surface lesions? In theory, that may be true. My experience has been from doing, God knows, I would roughly say somewhere in the neighborhood of 2,000 plus cases. Generally, all the lesions are not the same. Some are more advanced, some are less advanced and less invasive. And logically and intuitively, it makes more sense to remove something that's abnormal than to try to cover it up. And that's basically what ablation is doing. And why would you want to subject someone, to future surgery if you can do the most definitive thing as a first surgery to increase the likelihood that they'll never need another surgery? There's no guarantee, and I never guarantee patients that 100% certainty that you're never going to have another surgery, but this is the best way to stack the deck in your favor and minimize that possibility.
Okay, that was a very thorough response to endometriosis. So thank you for that. How accurate is the ReceptivaDx? And also, would you want to get an MRI first? How accurate is an MRI for diagnosing?
The MRI, roughly 20 to 25% of cases, you'll see some findings that are suspicious for endometriosis, which means 3/4 of the time, even though they may have it, you may not see anything. That being said, if you have something very classical, like an endometrioma, which is a cyst in the ovary filled with endometriosis, that will be more easily diagnosed. But even then, the radiologists tend to give you a list of possibilities. They'll say, given the clinical picture and the findings, this is most likely endometrioma, but could be a hemorrhagic cyst, could be another abnormality, or can't rule out carcinoma. They usually give you a laundry list. But the better radiologists that are really skilled and experienced will tell you it really looks like an endometrioma, and that's probably what it is. But usually by the time you're getting the MRI, the patient has already had an ultrasound, which they also saw the cyst, and they also gave you the same assessment that it's probably an endometrioma. I don't MRI every patient. I definitely MRI patients that I think that I'm suspicious that there's significant disease. For example, if they have a strong history, and on physical exam, I feel something, like I feel some nodularity or thickening on pelvic exam between the rectum and the vagina, which means there could be disease involving the rectum, or you feel that, and the patient also gives you a history that's worrisome, like of having like rectal bleeding. So you think maybe there's invasion of the rectum, and then that's where the bleeding is coming from. So an MRI would be helpful, so you can see, oh, there's a nodule in the rectum. Oh, I know that probably either I have to do a disc resection of that area, or I need to have a colorectal surgeon involved because we may need to do a bowel resection to get all the disease out. And it's the same thing with urinary issues. If there's a nodule growing in the bladder, or perhaps invading into the ureter. So you need to know in advance so you're prepared. So if you need a colorectal surgeon, or if you need a urologist, or if you need a vascular surgeon, or whatever other specialty available to do the case in tandem together. I spent a lot of time gathering my history from a patient, and I spend even more time counseling them and informing them, just the way that I just did in our previous segment, about what it is, what it can do, and what I may encounter, and how we're going to approach it, and what are the possibilities. Because I always find that it's best to, I wouldn't say over-inform, but maybe that some people think they're overwhelmed with too much information. But I think it's better for both the surgeon and the patient to be on the same page. And the more you know, the better you can make an informed, educated decision. And I like my patients to be partners in the process, not just a passive participant. So I think I answered
MRI question.
the
The
MRI
Receptiva?
question. And as far as the Receptiva is helpful. It's not diagnostic per se, and it's more common from what I've seen in my practice, in that subset of patients that have both pain with symptoms, but also have fertility issues. And the Receptiva is done. So that's another box check that gives you a greater suspicion that's what you're going to encounter. And many times it's helpful also because with endometriosis, there's no classical presentation. There's common symptoms. Not everyone has all the same symptoms. It's not like a lot of other conditions where there are triads of symptoms that are classical for a particular condition. I have a lot of patients who are referred by reproductive endocrinologists, and they come in, they're like, I don't know why she thinks or he think I have endometriosis because I don't have the typical symptoms. But even in those cases, once I start peeling the layers of the onion, getting into their history, they realize that they do have symptoms. They just thought they were normal. Like debilitating periods, a lot of people are told by their school nurse and their pediatrician and their mother's gynecologist that it's part of being a woman or part of growing up. And it's not. A period can be uncomfortable. You can have a fair amount of cramping, but it shouldn't be painful to the point that it's debilitating. And some of the hallmark answers that I always look for is I will ask people, like, think back to when you were a teenager, adolescent, in high school or before. Did you ever miss days of school? Oh yeah, like at least every couple of months or sometimes every month. And then now that you're working, do you miss days of work? Yeah, on occasion. I'm like, do you think that's normal? I mean, and then when you miss work, what are you doing? I'm just sitting at home with a heating pad on, taking Motrin like they're M&Ms, or I'm curled up on a ball like on the floor. And it becomes, all these scenarios become what I refer to as their new normal. And they think that's routine. And so they don't think anything of it. And the tendency, and it's human nature, you tend to adapt and you tend to live with the hand that you're dealt, so to speak. And when it comes to having symptoms like that, you live around them. So you know that you're having one of your pain episodes either related to your period or not, and I'll get into that as well after, and you prepare. You're like, oh, I know my pain's going to be really awful this evening, so I'm going to cancel my plans with my friends or with my spouse or my significant other because I know I'm not going to be functional. So that's not normal, but they think that that's kind of part of life. And to me, like, one of the most rewarding things is when people tell me like all these things that they used to live around or avoid are no longer factors in their life. So that's, it's tremendous because it's not something you want to be limited by for ad infinitum.
Does someone have endometriosis though without pain? Because I know a lot of times with fertility patients, I didn't have any pain.
So that leads me to another interesting statistic in the infertility realm. In the subset of patients who have what's called unexplained infertility, which it means they have had the $1 million workup blood work's normal, ultrasound's normal, the HSG, which is the dye test to see if the tubes are patent, that's normal. Partner semen analysis is normal. So the cycles are regular and very 27, 28 days. The periods are 3 days and blah, 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 blah. The next step in the algorithm of working up those patients is a diagnostic laparoscopy. So and that's according to the American Society of Reproductive Medicine. That's pretty much a guideline. In those patients, over 50% of them have endometriosis. And I've seen patients always ask me, like, how bad do you think my disease is going to be? And I always tell them, like, I can give you my educated guess, but I've been surprised so many times because there's no correlation between symptoms and findings. So you have patients with minimal symptoms or no symptoms other than fertility issues, and you go in there and they have extensive disease. Then you have patients with horrific symptoms, debilitating symptoms, and they have pinpoint disease, 2, 3, 4 little lesions. And you're like, oh, I'll take them out. But I used to think that can't be causing all their symptoms. And you remove it, and then you see them a few weeks later, and they're like, oh my God, you changed my life. I had my period, a little bit of cramps, took a Tylenol, and that was it, and I'm good. So there really is there's no rhyme or reason. And that's why it's really unfortunate that a lot of times patients are told, it's unlikely you have a lot of disease, so why don't you wait until you want to get pregnant before you do anything about it? Which makes no sense. The old school thought was that someone who's young, let's say a teenager or 20 or in their early 20s, how bad could their disease be? They must have just superficial disease. But now we know from a lot of surgical experience, from not only myself, but many others, and it's been published, we find teenagers, 14, 15 years old, with severe, deep infiltrating stage 3, 4 endometriosis. Why would you want to let that fester for another 5, 10, or 15 years when the individual is trying to get pregnant? Because it's usually a two-sided issue. It's symptoms and quality of life, and then fertility. And neither one is more significant than the other. And to some people, one is more important than the other, and vice versa. But why wouldn't you want to eliminate both rather than hobble along? So that's why I'm very focused on and keen on early diagnosis and treatment, because it's common sense. If you treat something in the early stage, you're not giving it enough time to develop, not only in the sense of it becoming worse disease, but also triggering all these other issues that generally go along with it, which leads me to the next important issue is it's not only a painful period condition. And that's what a lot of people think, because they don't connect or relate a lot of other coexisting issues and pain generators that patients have with endometriosis. For example, and this is what I routinely ask all my patients. I'm like, tell me what your symptoms are outside of your period, because there are cyclic symptoms related to your menstrual cycle, and then there's acyclic, meaning it comes regardless of where you're at in your cycle. But then, like, even when I'm not having my period, I can get these episodes where I get these shooting pains on my back, and I get these tingling in my toes and shooting pains down my legs, and like really very uncomfortable to sit for very long, especially on a hard surface, or I have back pain. I have a lot of bloating. I have motility issues like constipation, diarrhea, or what we call obstipation, where it alternates between constipation and diarrhea, just generalized abdominal pain, other GI symptoms like nausea, reflux, and the list goes on, and then it goes to other symptoms that are like not related to abdominal organs or structures, but people will have anxiety, depression, brain fog, forgetfulness, like memory issues, difficulty sleeping. And that comes from the whole pain side of endometriosis, meaning when you have pain or the sensation of pain, it's coming from a peripheral source. The way that your central nervous system processes pain is that signal goes from let's say it's coming from the right side of your pelvis via peripheral nerves to your spinal cord, which then take the message to your brain, processes the signal, and then sends a message back. When pain lasts for longer than 3 months, you've now crossed into the chronic pain domain, which is a game changer. So here, what ends up happening is there's constant pain signals during the course of the month. And so it becomes this two-way conversation between the source and your central nervous system. And the way that your central nervous system is wired is that the pathways are not linear. It's not like if you look at your light switch on the wall that's above the outlet below it, there's one wire that goes from one to the other, and that's where the power comes from. The central nervous system has a lot of redundancies and a lot of fail-safes to protect itself. And that's why, for example, like stroke victims can be paralyzed in an arm or an entire side of their body, and then they go for PT and they get rehabbed, and all of a sudden they're using their arm and their leg again because of the plasticity of your central nervous system and a lot of alternate pathways for neuronal signals to go other than the one that was damaged. The problem with pain, like with endometriosis, is that these pathways are the route that these nerve signals go, coming and going. And in the process, there's a lot of cross communication between the nerves that it encounters on its way to and from the source. And you get what's called neurology terminology is crosstalk. So the nerves basically communicate. So that's why the pinpoint pelvic pain then all of a sudden becomes bilateral pelvic pain, radiating to your lower back, radiating to your bottom or down your legs, to your shoulder and your neck. And then the other thing, so that's from nerves. From as far as the inflammatory effect, because endometriosis is an inflammatory condition, when these lesions release all these inflammatory mediators like cytokines and leukotrienes and all these wonderful things that cause inflammation. It's released into your abdominal cavity where everything else in there is exposed to it. So for example, with your GI tract, with your gastrointestinal system, these things inflame the bowel. When you inflame the bowel, it alters its function. And one of the things that it does frequently is it slows down motility. When you slow down motility, things are moving through the system much slower, which then does two things. One, you're more inclined to get constipated. And two, bacteria, normally have bacteria in your bowel. When you have a normal colony count, let's say for argument's sake, 10 million bacterial colonies, everything is in balance and things work well and your motility is good and you feel good, you're not bloated, whatever. If the motility is slowed down, so now bacteria has a longer time to hang out, and bacteria likes a warm and moist environment, it's going to overgrow. So if you now have a colony count of 50 million or 100 million, you have all these extra bacteria that does what? It releases the byproducts of bacterial metabolism, which are enzymes and gases. Enzymes cause more inflammation from the inside, and the gases distend your bowel and make you bloated. And then you get to a point where there's so much inflammatory material inside the bowel that it can't physically hold it anymore. And you get alteration of the permeability of the bowel wall, and you get what's called leaky gut syndrome. So all this inflammatory stuff then permeates through the bowel wall into your abdomen and pelvis. Now it's adding more inflammation on top of the endometriosis. And there's receptors, the same pain receptors for all these inflammatory mediators are in your bowel and your urinary tract and your genital tract. So they all play off each other. So it's people generally have multiple symptoms. So they'll come to you with, I have painful periods, I have pain with intercourse, for example, because there's implants in the pelvis, frequently behind the back of the vagina, between the vagina and the rectum or other places in the pelvis. And they say, I'm bloated all the time, I'm constipated. And typically they'll say, I'm constipated most of the month, and then I have my period, and all of a sudden I have diarrhea. Someone uncorked my bowel and everything just comes out, and then everything just resets, and then I'm constipated again after my period's over. So there's multiple layers to this. And the longer you let it fester, all these other symptoms tend to percolate, develop, and surface. So it's important to treat early, but it's also important to treat all these coexisting pain generators. If you don't, even if you do the surgery, it usually takes years to get to the point where most people are symptom-wise. So there's no magic bullet that's going to take care of everything. So surgery is the cornerstone of treatment because you want to get rid of the root cause that keeps triggering all these issues, but you also want to really downregulate all these other issues, meaning downregulating the central nervous system, which is so revved up because you have this chronic pain syndrome going on, and you want to calm things down. Generally, from chronic pain, your pain threshold is pretty low, so it doesn't take a lot to really debilitate you or make you feel awful. So resetting your pain threshold, which can be done with medications, which calm the nerves like gabapentin and Lyrica and things of that sort, and also rehabilitating a lot of the nerves and the muscles in the pelvic floor and the abdominal wall, lower back, where they've been irritated and stimulated so much that the baseline muscle tone in all these muscle groups is so tight, and that contributes to the pain. And then anything that triggers or gives you anticipatory anxiety about more pain. If you have pain during bowel movements, if you're having a bowel movement, instead of relaxing so you can have a bowel movement, you're tensing it up and tightening up more, which makes it even worse. Or if you know it's going to hurt when you have intercourse, you're going to involuntarily tense up more, and it's going to hurt even more. So you're trying to undo a lot of these knee-jerk kind of responses to external stimuli. So things like pelvic floor physical therapy to help relax, lengthen, and stretch these muscles and reset everything. Treating the pain, treating the GI issues. That there's a common condition. A lot of endo patients get labeled as IBS, which isn't a diagnosis, it's a description. It's irritable bowel syndrome. The thing I always ask is, why is the bowel irritable? If someone doesn't have intrinsic GI disease, so Crohn's disease, ulcerative colitis, celiac disease, or some other malabsorption syndrome, whatever, why is, your typical patient, why is this 25-year-old person have all these issues? And so if you have that inflammation and that overgrowth, which is called small intestinal bacterial overgrowth, you want to treat that. And that's something that needs to be treated with antibiotics. And it's a 2-week course of oral antibiotics to knock out all that bacterial overgrowth and reset everything. So the goal is to get rid of the endometriosis, fix all these other issues, kind of recalibrate and tune up everything so you start from the best place possible moving forward, rather than limping off, feeling a little better, but not 100%. So it's really important to take a multimodal approach to treatment. Otherwise, you never really get to the best place possible. And that's one of the things I always really impress upon my patients and emphasize. If you understand what's going on and why these things are happening, then it's much easier to commit to a plan. And even if it takes months, knowing that it's working and starting to see improvement. And that's why even patients who are not like ready to have surgery right away, I will start treating all these other things first, because there's nothing better than someone realizing that, oh my God, like he said, this was going to feel better and that was going to feel better, and it's working.
So after excision surgery, a lot of people are doing this because they want to have a frozen embryo transfer work.
Right.
They've had failed transfers. Do you then still recommend them going on some kind of suppression, or do you recommend them trying naturally? Do you recommend them going straight to an FET?
Yeah, so it really depends. It depends on their history, the patient's age, what their goals are. Do they have frozen eggs or frozen embryos, or are they just starting out? It's very individual, and that's frequently why I work in conjunction closely with the reproductive endocrinologist to really understand what their trajectory is, their plan regarding that, so we can work hand in hand to really get them going in the right direction. I've had my share of patients who, while they were recovering from the surgery, they got pregnant spontaneously after multiple failed cycles of IVF and a horrible reproductive history. And that's what kind of brings me to another point, is people think that unless the disease is on or in the ovary, it shouldn't be affecting your egg quality, egg production, and the viability of eggs when they're harvested, and how well they fare. Just the presence of endometriosis implants in the abdomen and pelvis kind of pollutes the environment for the ovaries as well. So you can see decreased egg production, low quality, poor egg transport. It could interfere with fertilization. It can interfere with implantation. So you'll see patients, there's the extremes where like they either IVF never takes at all, or then there are ones that are once in a while, or many times it'll take and then they'll miscarry in the first trimester. And that's usually either an egg quality issue or an implantation issue, because you remember the tubes are a conduit from the inside of the uterus into the abdominal and pelvic cavity. So anything, it's communicating with the internal organs of your body. So anything that's in your abdomen can get into your tubes. So you have inflammation in the tubes, you have inflammation in the endometrium, and that's what you see also in the Receptiva test, or even just on a straight up endometrial biopsy. You'll see this chronic inflammation with a lot of white blood cells and all the telltale signs of an inflammatory response. So you want to eliminate all that to maximize the chances of success, either spontaneously or with IUI or with IVF. But that's really the goal, is to remove that impediment that's blocking the process, which can be from many different stages.
How should IVF protocols be adjusted after the
Yeah,
surgery?
so it depends. So like most REIs, reproductive endocrinologists, will downregulate patients before they stimulate them for a cycle, which really optimizes the whole process, because you're getting a more pronounced response when you do the suppression. So I'm totally okay with that. And that's really, in my mind, as far as in my sphere of practice, that's the only use for something like Lupron. It's not something that I recommend patients take as a treatment for endometriosis, because it's not.
Expand on that more?
Yeah. So there are two classes of drugs that are commonly used, which are GnRH agonists and GnRH antagonists, which is gonadotropin releasing hormone. So Lupron is a GnRH agonist, which basically shuts down your ovaries and puts you essentially in a chemically induced menopause. For a short spurt, when you're doing it to induce a cycle for IVF, that's fine. The problem arises when you start treating patients with it long term. Then you have some reversible and many irreversible side effects of being in a chemically induced menopause. And there's no end game. It doesn't treat endometriosis. It may minimize some of your symptoms during your period or related to your cycle. And it's equally as effective as a birth control pill. And the birth control pill doesn't have the kind of side effects that Lupron or Liso, which is a GnRH antagonist, also, they're not meant for long-term use. And if you look at the FDA indications, both of them are really just for short-term use, but people treat patients off-label and keep them on it for a year, 2 years, or more. And then they're left with horrible menopausal symptoms and some of the irreversible side effects, which are like cognitive changes, bone density loss, increased cardiovascular disease risk, et cetera, and so forth. And the list keeps going on. So in a nutshell, something like Lupron is fine in preparation for a cycle, but it's not something that's a treatment. There's no conservative treatment for endometriosis, be it Lupron or Liso or the birth control pill. All they do is possibly, for some patients, decrease some of the pain, but it doesn't treat anything. And I've seen patients who've been incorrectly told, oh, it'll melt away your disease, and does nothing of the sort.
Someone asked about naltrexone.
So that's something that's more recent over the last couple of years. It's effective for some patients, and I find that it's more utilitarian for some patients post-treatment, so post-surgery. It can give you some symptom relief even without having surgery, but again, it's a Band-Aid on a problem. It's not a treatment. It's not anything that's going to either delay or slow down progression of disease, and it's not a long-term game plan.
Okay. I'm going to actually let everyone who's here ask their own question. So if you have a question, raise your hand and then you can unmute yourself and ask the question. Anyone have one?
Okay. Is it feasible for someone with endo to get pregnant on their own, or is IVF always the answer?
I would say it's about a 50-50 thing. So probably half of patients with endo have no problem getting pregnant, and they do, and they carry the term and they have no problem. And then the other half have varying issues with conception and miscarriages and et cetera and so forth. But that being said, also sometimes it can, as the endometriosis progresses, it can create problems where you didn't have problems. I have some patients like they've had one child or two children, now they're trying to have the second or third child, and they're running into all kinds of issues getting pregnant. Because it's a progressive condition, it can manifest more issues with fertility in a delayed fashion for some people. So it's by no means is it like a absolute given that that you'll not be able to conceive spontaneously just because you have endometriosis.
So
Sure.
I had endometriosis diagnosed starting from early 20s, and then had the surgery to remove the ovarian cyst. And now right now I'm in the early 30s, and my symptoms are coming back. So specifically the pain and also the symptoms related to bowel movement, constipation, and also diarrhea. So right now, because I'm getting older, I'm also considering the egg freezing or embryo freezing to preserve my fertility, because I do not have pregnancy plans in the near future. So I'm wondering what will be recommended out there. Shall I do the surgery to treat the endometriosis first, or shall I do the egg freezing or embryo freezing first? And what should be the factors I consider in deciding the order? Thank you.
Yeah, I think if it doesn't look like you have endometriomas in the ovaries, then what I would suggest is seeing a reproductive endocrinologist for an evaluation, and they'll do another ultrasound just to make sure, because sometimes ultrasounds are only as good as the person doing the procedure and how well they are, how good they are at reading it, to see where you're at right now. They'll also check your hormone levels and see if you're ovulating properly and how many follicles you're making, and then they can make an assessment. If it doesn't look like you have endometriomas and you're making a decent amount of follicles, then it'd probably be wise to do egg retrieval first and then surgery second. In the instances when there are endometriomas, or it looks like there's disease in the ovaries, and or the numbers don't look good, you're not making a lot of follicles and they're not really mature follicles, and your cycles are a little off and the things don't look 100%. For those situations, like I was saying before, when you have endo that is affecting the ovarian function, it's more prudent to do the surgery first. So then you get better ovarian function and better response to cycle stimulation for egg retrievals or for IVF.
Question that Rachel asked earlier. So I've already made up my mind that I'm going to have the surgery. I'm pretty sure that I have endo. And my sister actually had a cyst removed, a dermoid cyst, on Monday, and they found endo.
So that, just not to interrupt you, but that genetic part of things, your sister, aunt, grandmother that has endo, and you have symptoms, you have a 70 to 100% chance of having endo.
Hers was stage 2. I'm pretty sure mine is way worse, because I've always had really painful periods since I was 13.
But you don't know. And the thing that I always tell people is don't get hung up on staging. Staging is really more of an anatomical sketch of what's going on. It doesn't mean that it's worse in the sense that you necessarily will have a harder time getting pregnant or not. It's really a descriptive modality that was created by the Reproductive Endocrinology Society, the ASRM, to rank the stage of involvement. And they've been working for, God knows, more than a decade on redoing the staging system, because it has like parameters. If you may have minimal stuff going on, but you have one element that upstages you have an implant on your rectum, or you have an endometrioma.
So I was going to ask, so I did have an early stage miscarriage from a healthy embryo that was genetically tested. And so that's why I'm like on this journey of, okay, let me look at the endo, because I do match a lot of the symptoms that you described earlier. But I have a question about the Lupron. So one of the things that was suggested initially was that I could do Lupron for 3 months to prepare for that embryo transfer.
That's pretty standard.
If I do the surgery, though, is that something that is still recommended, or is it on a case-by-case basis? Is it possible for me to do a natural modified cycle, which is what we ended up doing? And it did stick. It's just I lost it later on.
That I would leave up to the reproductive endocrinologist based on assessing you as you prepare for that cycle. Most will opt to use it because you really want to get a more kind of turbocharged, enhanced response, which, is helpful. And the other thing to also keep in mind is, unfortunately, as you get older, the statistics get worse. So what may have worked a year or 2 or 3 years ago, at this point, may need a little bit more of a kick to get it going.
Thank you so much, Dr. Orbuch, for answering everyone's questions on
My
endo.
pleasure.
And I hope you have a wonderful evening. So
You as well. Thank you so
Appreciate it.
much.
Thanks, everybody.